Professor, what could you tell me about your background and qualifications?
Sure. I'm trained as a historian, as a Canadian social historian in the history of health and disease in Canada. So I started out as a political scientist when I was young, and then switched to history when I was getting ready to do my doctorate, which I did at University of Manitoba.
Fantastic. And so in your research on the history of health and disease in Canada, which pandemics have you studied so far, or epidemics?
Yeah, my main focus is the history of the big influenza pandemic at the end of World War I. I do teach, though, the history of infectious disease in the modern world. So that, taking that sort of big world scope, looking at things in that big picture really makes a big difference. So there are a number of diseases that I study and teach when I teach that course. So everything from the Black Death through HIV/AIDS. And I think it's something students are really interested in, is looking at different historical experiences with epidemic disease outbreaks. And then, of course, diseases like tuberculosis, for instance, or HIV/AIDS as well, that have quite a long-term impact over a number of years or decades on a population. The pandemic that I've done most of my own writing on was fairly short-lived in comparison to ongoing disease threats like tuberculosis, for instance. Not that influenza itself was short-lived, but that a variant of influenza that killed so many people has only occurred that one time in modern human history. So more episodic.
Yeah, that's a good point.
In human history, we've seen a number of pandemics, epidemics, smallpox, cholera, influenza, like the big one in 1919, diphtheria, polio, HIV/AIDS, newly emerging diseases. Can we draw any parallels to what happened in these cases to today's COVID-19 pandemic?
Yeah, look, it's a good question. I mean, every disease is unique in some way, right? It has its own nature and its own biological relationship with humans. But historically, disease is embedded in the societies in which it takes place. And so there are historical parallels and differences, of course. When we look at these things, sometimes it's just as important to look at the differences between disease events as it is the similarities. When it comes to the evolution of modern public health, so everything from about the mid-1830s until the present day, there are very important continuities that have shaped the development of modern public health. Some of them, like quarantine practices, are of course even much older than that, and date to the Black Death. But because we are really now still living in a system that was shaped in significant ways by the emergence of germ theory, the bacteriological revolution, and the sort of invention of modern public health, like epidemiology, for instance, in the 19th century, it's important to know that history because we're still very much influenced by those past practices and this kind of continuity in the way in which public health has emerged in countries like Canada.
That is good to point out. And just in follow-up to that, some of the illnesses and diseases that you mentioned, and even the one influenza that you mentioned that you've studied more in depth, how would you compare COVID-19 spread with some of these diseases in terms of their scale as pandemics? And what factors do you think have contributed in the spread, and what safeguards would basically help curtail future spread of similar pandemics?
Mm-hmm. Well, the influenza pandemic at the end of World War I was, like COVID-19, truly a global pandemic. there were very few countries in the world that escaped it entirely. There are, of course, places that had fewer cases and a better experience, but there's quite a lot of overlapping experiences globally that we can gather from that pandemic. So the similarities between COVID-19 and that pandemic are, there are some important pieces to that, right? Public health measures, in some ways, setting aside vaccination for a moment, are very similar. So public health advice about limiting exposures to crowds, staying home when you're sick, the use of masks, which had emerged by 1918. Support for using masks was somewhat limited because keeping them sanitary at that time was sometimes a challenge. The use of temporary isolation, either self-isolation or isolation in a hospital, was also used. And, there were also significant differences. So the early 20th century was characterized by a lot of infectious diseases, many of which, you mentioned also, diseases like diphtheria or measles or tuberculosis. So the society in the early 20th century was in some ways better accustomed, just through experience, personal and family experiences with infectious disease, had, I think, a kind of a greater intimacy with infectious disease than most of us do who live in wealthier countries in the global north right now. This again would be different, of course, if you lived in the global south, where infectious disease has remained really fairly prevalent through the 20th century, even as it's declined in countries like Canada. So the familiarity with public health, I think, was higher then. The tools were more limited, though, and that's true for therapies, for instance, and it's also true critically for the opportunity to vaccinate. So there were attempts to create vaccines in 1918, but the science of virology wasn't well developed enough. And it isn't until 1933 that we even have topologies of viruses developed. And the influenza virus, viruses are isolated. And then quite some time after that, before we begin to see the first effective vaccines. And influenza presents, like coronaviruses, real challenges in terms of the mutability of the disease and the way in which the disease can alter itself. And being truly global, it has all kinds of different geographic locations where that mutation can take place. So influenza offered, the pandemic offered some real cautionary notes. But, COVID-19 has also, I think, been the extent to which we have successfully developed vaccines. That's a success story. The limited extent to which we've made access to vaccines global and made it equitable globally, of course, is less successful, right? So again, we're looking at some populations globally who don't have the benefit of vaccines. And so their risk factors are quite similar to sort of early 20th century risk factors for dangerous infectious diseases and viruses.
Well, that's a very interesting historical perspective. It's that people back in, the flu pandemic 100 years ago, they probably knew, infectious disease that visited them on a frequent basis. People were experienced, unfortunately, with loss as well, especially younger ages. So that probably paid a big difference in the responses. But like you mentioned, the inequity in distribution, we're seeing that story played out even today.
Yes. Yeah, I think, people who work in the healthcare field are very familiar with the impact of inequity. And it's not as if we don't have health inequity in Canada. We have it here too. And we certainly have it globally when it comes to, just the difference in resources or the structural factors increasing people's risk to to not just infectious disease, but all kinds of diseases. So the story of inequality and disease is a long, very old one. This is why I think so many people early on during the COVID outbreak were really speaking about the importance of paying attention to social inequality and not to make the assumption that the disease, the pandemic would affect all groups equally. We kind of knew that early on, not just historians, but all kinds of people were making that argument. I don't think we really effectively acted on that knowledge, and we still have, I think, inequalities in COVID that our knowledge of them will continue to emerge as we go on and we do sort of deeper study of what we've been through and what we're going through now. But even preliminary data suggests that health inequity is very important, as it was important, more than 100 years ago during the flu pandemic. Same, very similar issues at play there.
Switching gears to a different sort of problem that probably was present in that pandemic is, did misinformation play a big role in previous pandemics as it has in the current one?
Mm-hmm. Yeah, I mean, misinformation historians don't usually speak in terms of misinformation, but there are sort of parallel concepts that we use, like conspiracy theories, for instance, and I mean that in a relatively value neutral way, just looking at those experiences from a historical perspective, those health inequities, for instance, and the way in which poor people were treated during outbreaks of diseases like cholera or early 20th century outbreaks of plague, say in places like India, or tuberculosis. The lack of trust in government and in public health was a significant factor in really creating different interpretations of what was going on as people went through these experiences. And of course, information was shared between people and through various print vehicles, or through word of mouth and so on. And you do have different narratives about disease. And some of those we might consider misinformation. Today we might use that terminology. But I think it's also important to understand that a lot of those feelings about, say, vaccination, for instance, are deeply rooted in social relations. So the facts are important, but they are maybe not the only thing that's important in the way stories about disease emerge. And during World War I, one of the most significant conspiracy theories in places like Canada about the emergence of influenza was that it was a form of German biological warfare to try to end the war. So those kinds of ideas, I think, serve a need at some level for people who are persuaded by them. And they aren't necessarily faulty reasoning or conceptual flaws, or they're rooted really in people's social experience.
Sorry, I just want to follow up on that, because that's a really interesting point. Like, what can we do to ensure that that message gets across, despite, there might be some folks who are socially predisposed to, that environment? Like, what can we proactively do in those cases that you've seen historically?
I think the long-term relationship of between, the sort of outward-facing aspects of health and medicine, public health, medical treatment, that presence in people's lives and the nature of that relationship is really important. So I know sometimes during COVID, public health leaders have drawn on, say, community leaders, either faith-based leaders or other respected members of the community, to promote public health measures and to try to convince, right, that people should feel safe and comfortable following that public health advice. So that's one piece, I think, is to try to find a way to generate that trust. And the other, the other thing is to recognize that what may appear to be a certain kind of thought process might actually be some very real barriers that people face, socioeconomic or other barriers to accessing health resources. And one of the reasons I think Canada has done on vaccination, for instance, relatively better than the US, is that Medicare actually shapes people's relationship with the health system. So it was a while ago now that I read a piece, I think it was in the New York Times, and I can't remember the exact data, but a critical mass of people who are not vaccinated in the US have no health coverage. So it's an illustration of what I'm trying to get at, that the accessibility of healthcare and the way in which it's formed has an opportunity to be formed in a relationship of trust is really important. So, in Manitoba, we've had a lot of Indigenous and First Nations people working to improve outcomes from this pandemic relative to Indigenous outcomes in the past. And they have been successful to a significant extent. And a lot of that has to do with Indigenous healthcare workers, for instance, spending a lot of time in communities, making people feel safe and giving them public health advice, talking about masks, talking about vaccines and so on. So I think there is both there's an actual need to address accessibility in our healthcare system and other socioeconomic barriers to healthcare. And then there's also a need to make sure that there's some thinking about how to make the relationship between public health and healthcare as strong as we can make it in vulnerable communities.
That is very interesting to say, and it's also very important points you made. So in terms of examples of successful state action that contain pandemics in the past, are there any examples that have exacerbated or have made state action in the past successful?
Mm-hmm. Well, there are lots of examples of failures historically, of course, and those are usually pretty complicated. And that, also they tend to be the ones that we study as historians, right? The ones where something went wrong. One of the things I've said a lot over the last couple of years is that the global flu pandemic can't really be considered a successful model. Since between 50 and 100 million people died from that pandemic. But it is an important learning opportunity. So some of the things I think went wrong, well, some of them have to do with the level of scientific knowledge at the time or the lack of availability of effective medical treatments. But there were other pieces too, like a very limited ability for people to stay home from work, for example, if they were exposed or infected. So, there were not really any legislative protections or sick leave of any kind that people could access. So even though there were closures, public closures, to a certain extent, they mostly involved schools, religious services, and to some extent discretionary leisure activities like going to the movies or going to a pub. And those were closed for limited periods. Often those closures were instituted too late and they were too short in order to really drive down the number of cases. But there were also other problems with healthcare in that era. There was no Medicare, so a lot of people had basically no access to care when they became ill, and the extent to which they did have access to any kind of care, it was often voluntary in nature, voluntary organizations or neighbors or members of the community. So our healthcare safety net at the end of World War I was very minimal, right? And this is, I think, one of the things that contributes to very important conversations that took place in Canada between the early 1920s and the middle of World War II about the importance of introducing Medicare. And those really took off during the Depression years, partly because physicians and nurses tended to support it more at that time because of the financial problems with getting paid if you were a physician or a nurse during the Depression. But there's a really important history between the devastation of the flu pandemic and the introduction of the first Medicare programs in Canada, which were introduced in 1946. So, you know, there are some things that we can learn from that past about, I think, things that are really things that we can take action on. Right, that we don't need to consider ourselves sort of passive in the face of infectious disease. And again, it speaks to some extent to the importance really of long-term planning and the difficulty of crisis-based intervention. These things took many years to evolve, but I do think make a difference.
Or when moving from the state to the healthcare workers, we've seen enormous stress on healthcare workers during this pandemic. And I remember, you know, when I was a medical student, our professor showing us all the nursing graduating classes were wiped out during the flu pandemic in 1919. Like, what did this pandemic and past pandemics show about the impact on healthcare workers, their roles and responsibilities, you know, their ability to provide equitable access to healthcare resources?
Mm-hmm. Well, I think a health crisis is always incredibly difficult for people who are working on the front lines of healthcare, and they have been in the past and remain clearly very vulnerable, right? I mean, we've been better able to protect healthcare workers today from contracting COVID than was the case in 1918-19, when many healthcare workers contracted it and died. But the extreme stress placed on healthcare workers, of course, is very similar. And what you're asking of people, whether they be, you know, student nurses, a lot of people in working to provide care to flu victims were students, nurses in training, or physicians in training. So you're asking a lot of people and placing a big burden on them, and they do respond in this, you know, really very heroic way, as do many in 1918, many members of the public. But there's no real, I don't think there's a really easy way to solve the problem of the crisis generated by a very significant disease outbreak. So I think in Canada today, we're facing real capacity issues, especially in nursing, that were there before the pandemic and have been made a lot worse since the pandemic started. But to some extent, to be fair, it is difficult to plan for the human resources needs of a pandemic. So I think the choice now is, how do we generate basically more wiggle room in the system? Because many systems have very little wiggle room, right? And people need to be valued for the work that they do. And one of the things that people talk about in the public about the 1918 influenza pandemic is the extent to which there wasn't really much long-term recognition of the work that physicians and nurses and all kinds of others performed during the pandemic. And certainly in the years following, commemoration and, you know, a celebration of heroism was mostly about war veterans, right? Because it was so important in Canada after World War I to tell the story of World War I victory. And you may know that the flu pandemic was for a number of decades really forgotten historically. And, there are a lot of things you lose when you do that forgetting. You lose the experiences of ordinary people to historical memory, and you lose the contributions that were made by people who cared for victims. Because, remembering is also about honoring people's contribution. And I know that there are conversations happening right now about how we might do that. And I do believe that's very important. We did not do that as a society in the aftermath of the flu pandemic. And I think that this left a lot of people with this kind of hole where that part of their life was. Even childhood survivors of that pandemic really didn't have a way of interpreting their family's experience because it was almost like a secret, the losses of that pandemic. They were so seldom discussed. So it's important really to take a look at that and pull it apart and really find a way to hang on to the importance of those experiences.
I know that's a theme in your book. I think it was Epidemic Encounters, Influenza. That you mentioned that along with the staffing issues, and along with that theme, where sort of the influenza pandemic has sort of left our memory. A lot of the measures that were brought in, like masking and stuff, were also contested then, but effective, but then forgotten, and then had to be brought back with great opposition again. Previous pandemics, there was that tackling between the balance of individual rights versus public welfare. How was it managed then? And were there any insights into the legal and ethical issues of pandemic mitigations that we can learn from and apply, and hopefully not forget the lessons as this pandemic hopefully winds down?
Yeah, that is a really important question. And at the end of World War I, public health had already started to develop a professional culture that was quite opposed to compulsory measures. So the idea of health education was becoming increasingly important. And, historians talk about, for example, the quite deep campaign to lower infant mortality that began in the very early 20th century, which was mostly successful, actually, in lowering rates of infant mortality. And those were, they were kind of contradictory. So on the one hand, public health officials, nurses, doctors, administrators tended to emphasize the ignorance of the average mother as playing a role in high infant mortality. But on the other hand, their efforts were really based in a belief in health education and the importance of reaching out into communities to talk to people, right? And to reach people where they lived and to provide supports for them. So in the period after 1918-19, which was, really a very devastating event for a lot of physicians and public health people who were just sort of gobsmacked really by that pandemic, and because of where it falls in the trajectory of public health, where you're just coming out of that golden age where they had isolated a whole bunch of disease organisms and they were starting to develop, some vaccines and better modes of prevention. And then you have the influenza pandemic, against which most of the strategies that were used were not really effective, right? And you had a real reckoning after that. But to me, part of the reckoning that comes out of that is really this awareness, first of all, of the importance of cooperation, which is not completely new, but becomes new in that context. That the way in which you get the public to follow public health orders is not through compulsion, but through persuasion. And the other key piece for them is to put more resources into vaccine development. And I wrote an article about it and many years ago now, and it has resonated with me throughout the pandemic, because even now, public health, more or less its default position is persuasion and education, right? Which I think is really reflective of 20th century experiences with infectious disease. But as we went on longer and longer with the pandemic, mandates entered the picture for a number of specific reasons. So you have countries like some of the Scandinavian countries, for instance, with very high vaccination rates, but no mandates. And then you have countries like the US that have no mandates and very low vaccination rates. And so the decision now is to think about developing the best path going forward. And is it possible to really support and generate what some of my colleagues call a culture of public health, where there's what you were referring to, this kind of is there a possibility of not forgetting everything, but kind of having this ongoing relationship with what we've learned and what has worked, and allowing people to, really take that on board and having a greater ongoing awareness of public health risks, which I think, probably both of you grew up with only minimal infectious disease risk in your lives, right? Yeah, but it's not that long ago, right? Like even I had many infectious diseases as a child. I had measles, I had mumps. I didn't have any of the truly horrible ones like diphtheria, but I was tested for tuberculosis. I had the polio vaccine. So it's not so far away in the distant past that we can't again begin to cultivate that kind of culture of public health.
And so in terms of everything that you've mentioned so far, and I think you mentioned it earlier as well, in terms of the equitable impact on certain groups, how has the social impact of, infectious disease impacted ethnic minority groups and individuals of low SES or immunocompromised individuals, or even older adults, like we're seeing with COVID-19 and older adults today?
Mm-hmm. Well, racial inequality is obviously really important in that story of health inequity. And, all the data is leaning that way and has been really for a while now. And, it's not enough just to be aware that those inequities exist. There need to be ways to address them. And, the disparities of COVID-19, I think are, I think even between the beginning of the pandemic and where we are now, there's been in some ways less attention to inequity than there was, say, in the first year. And I think some of that has to do with, the coincidental emergence of Black Lives Matter, for instance, which, you may remember really kind of was reaching a peak at the start of the COVID pandemic. And there was a powerful way in which the two became commingled. And there are always a lot of sort of pressures toward the reestablishment of the status quo. And that's one of the reasons why returning to normal is not exactly what we want here. We want to do better than just returning to normal. Because there's no reason to believe that those inequities won't continue to play a role in shaping people's experience. And I think there's still a lot of unpacking to do there, looking at what, others would know better than I would. What are the underlying drivers of those inequities apart from racism? What pieces of it are most important? Is it housing? Is it income levels? Is it migration status? Is it what are the contributory social factors there, and how do they fit together? And then you can come up with policies that might begin to address them. In the post-1918 world, the push the push to return to normal that we feel now was it was very intensified at that time because it was also the end of World War I. And so not only were people exhausted by, an intense series of months with a very deadly disease, but also by 4 years of war. So the pressure to return to normal life, whatever normal life might look like, was really very high. And this, of course, didn't work for everyone, which I think is one of the reasons why you see a very significant wave of labor revolt in Canada in 1919, a series of waves of strikes really across the country, most intense in Western Canada, where I'm from, but it existed elsewhere too, where returning to normal meant, really returning to a life of poverty, particularly for those people who were now experiencing some form of disability, whether it was a physical or mental health disability as a result of their war service, or some long-term effects of influenza, because there were those as well. So I think now we need to sort of consider how we're going to address things like long COVID, for instance, and how are we going to address the loss of breadwinners? And measures need to be taken, in a recognition that we do know that those things will have an impact, and that we shouldn't have to demonstrate over and over and over again that those inequities exist, because we know they exist. And it's more a matter of fine-tuning how one might respond to them, I think.
Before Andrew asks that question, I guess in this case, we're getting the pandemic and then the war. So we reversed the order.
I know. And that happens sometimes historically, actually. It happened too with cholera. You had sometimes they were in one order, and then when cholera, which was a new disease in Europe in the 1830s, you have it all messed up with revolutionary movements in that period, some before, some after. It's fascinating. I do think I haven't seen anybody writing about the spread of COVID in war-torn regions now in the Ukraine, or even in the Russian military, because when the invasion of Ukraine began, that part of the world had one of the worst COVID infection rates globally, and it didn't just disappear, did it? Because there was an invasion, and yet we've heard very little about that.
It's almost like you don't see any of the leaders' masks. You almost think it's over there, I guess.
Yeah, but the New York Times global map, that was the darkest region in the globe at the start of the invasion. So, in the Ukraine itself, it must be impossible to even keep track of COVID at this moment. And I don't know specifically how the Ukraine did with COVID, but there must be massive risks there now in a place where infrastructure is basically broken down.
You mentioned the link with cholera. Like, do pandemics act as an accelerant for conflicts? Can they provoke conflicts even while they're disabling or killing a lot of people?
Yes. Yes, there's lots of historical examples of that because they expose weaknesses, they expose inequalities, and they also expose the ways in which the state lacks legitimacy, because during disease outbreaks, it is the state that's responsible for trying to respond, right? That's what we expect of our governing bodies, or, in the world before the modern state, it might have been the church. We really consider them to have an important role in marshaling resources and to act and intervene. And when that fails, it always undermines the legitimacy of that governing order. And where there are already pressures, they often erupt. And sometimes they're very small and localized, and other times they have a bigger impact. So, it does depend on the circumstances. It's not infrequent, though.
So of course we can't talk about the impact of infectious disease and pandemics without really touching on the effects that it has on the economy. So based on your knowledge, how did the consequences of infectious disease and past pandemics really impact global trade and national economies, and then in that context?
Mm-hmm. It's not one of my strong suits, economic impacts, but I have done a tiny bit of research into other people's work on it. There definitely was an economic, trough during the global flu pandemic, for instance. But then you see pretty rapid, and this is just measuring very crude economic measures like, gross national product or gross domestic product. You do see a rather, pretty quick recovery, right? So and this makes sense in some way, that the economy sort of contracts in the midst of a health crisis and then recovers. What that recovery looks like and how people are impacted as individuals or as social groups is, that I think varies a great deal. The 1918 flu pandemic had a very different age demographic than COVID has had so far. So the majority of people who died in that pandemic were between the ages of 20 and 50. So you're really taking out significant numbers of young adults with young families. So it has a different kind of social breakdown and social implications, I guess. When it comes to trade and the movement of goods and people, I mean, really the oldest disease control measures that there are going back to the Italian city-states during the plague is, the use of borders, right? Whether those and quarantines, whether they're maritime quarantines, if you're living in an area that's bounded by an ocean, or land quarantines, what the French called cordon sanitaire, to try to stop the movement of people in and out of an infected region. And, those were measures that were understood to be important at certain moments, but they were also measures that were often not enacted quickly enough or effectively enough. So, there's a cholera outbreak in Liverpool, which was a major port in England in 1832. And, the business community actually and public health kind of actually didn't really, they essentially hid those early cases of COVID so that they didn't have to close the port because of concerns about economic activity. So the importance of economic activity is kind of a two-edged sword, right? I mean, you want to maintain economic activity as much as you can, but you also want to ensure that there is still room for decision making that negatively impacts it, because it is one of those key public health tools. By the early 20th century, the maintenance of borders, for instance, national borders and regional borders, was considered a key public health measure during a time of very, very significant human migration. So if we think of countries like Canada and the US in that period, which were welcoming literally millions of immigrants between, say, about 1880, 1890, and 1910, border control was very different from what we see now. So, there was at places like Ellis Island, thousands of newcomers were inspected by public health inspectors as they arrived in a procedure that wasn't very thorough necessarily, because all they were doing literally was looking at people. But it was necessary to this partly for reasons of perception, so that you weren't admitting infectious disease into your country when you admitted newcomers. So the history of migration and disease are very, very closely intertwined in that early modern and early 20th century period. And the maintenance of these of this kind of ability to stop the movement of goods and people was considered essential. And then, by the 1920s, the overall response in North America to migration is to basically close it down, right? And so a lot of those pressures that public health faced during mass migration were sort of softened up a bit because World War I really ended mass migration to North America. So then the rules changed and greater international cooperation emerged as the important tool. So immigrants now were inspected at their point of departure, not at their point of arrival. So all of those measures were complicated, right? So if you wanted to keep diseased immigrants, and even maybe more, I say that with quotes around, maybe more importantly, governments wanted to be seen as preventing that. But at the same time, you needed, in countries like Canada and US, you needed these new workers. Your economy couldn't grow without them. So there was this constant tension between, the disease anxieties of the age and the need for basically unskilled laborers from all over the planet. So there's a lot of history there that we could kind of choose from at this moment, I guess, in terms of how we regulate the movement of goods and people going forward.
That's a really interesting point, that governments would basically take on measures basically to look like they're doing something. And maybe we had an example of that here when, there was travel testing, even though the virus, pretty much is everywhere now, that we maintained travel testing up until, this week, extending this week only. And so we're seeing that even now.
And with the truckers convoy also, right?
Oh, yeah.
It is, the politics of it are complicated, and there's nothing especially new there, but yeah, it is really interesting.
So there's in the medical world, there's been a lot of resistance, even from researchers who say there just wasn't evidence for certain measures like masking. We had to our group Mask for Canada actually had to break through a lot of institutional resistance when we were lobbying for mask mandates 2 years ago, right at the outset of this pandemic. Were there lessons on things like these measures that were forgotten from the flu epidemic? Did they significantly affect the outcome of epidemics and pandemics in your experience, in your readings?
Yeah, it's a good question. I'm not sure that masking would have, I don't think it was as sort of widespread and consistently done as it would have needed to be to prevent the spread of that influenza. And of course, the capacity for sanitary, the availability of good, high quality sanitary masks that would actually filter out a virus. I don't think it was really there, right? Some provinces made masking mandatory. Alberta, ironically, was one of those. And others rejected mandatory measures. And there was, maybe not so different from what you experienced, a lot of debate, right, about whether it would be effective. I think the difference, a key difference here today is the problem of time. So to some extent, what public health did or didn't do really took place between the end of September and at the most maybe February. So we're not talking about the 2 years of persistence and ongoing need for public health measures. Not that influenza went away entirely, it didn't. I mean, there was still very serious outbreaks in 1920, but public health kind of decided that was it, right? They were done with it by February, March of 1919. So it's because so much time has passed during COVID, I think it alters the landscape of debate. And there's also just such a massive amount of research on COVID that's available to people now. And I don't know whether that's, research is good, but is the absolute abundance of published research on COVID, is it helpful at the moment? Some maybe to some extent, yes, and maybe not, because decision making is already incredibly complex, and we are learning in real time, and that that real time is not has been now going for 2 years. So when it comes to mandates, as I mentioned earlier, the tendency among a lot of public health people at the time was to worry about the problem of compulsion. But one of the reasons that was such a concern during the flu pandemic was that there was no test for flu, no lab testing available at all. So when people's homes were placarded, right, when they had signs put up on the door of their homes to say that there were infected people inside, you couldn't prove that the person was infected with that virus. A public health person was purely going on, symptomatic diagnosis, right? And so many people complained about the arbitrary and unfair nature of it. So arbitrariness, fairness, all of those ethical principles, I think, come into play. And those were lessons, I think, that were very much on the table in the period after the flu pandemic.
Okay, so I'll ask you our final question. Basically, we're probably going, maybe possibly into a 6th wave of COVID now. It's uncertain like what impact it will have. We've sort of been wavering between extremes throughout most of the pandemic. What and I think the influenza pandemic had a number of waves as well. Like, what was the social impact at that time of that sort of swing back and forth, that wavering between extremes of safety measures, of outcomes during the pandemic, and what does it teach us now? Like, what does it tell us to do now exactly?
Mm-hmm. Well, that's an interesting question, because historical work on that influenza pandemic has really focused very heavily on the fall 1918 wave, and then to some extent included the early winter 1919 wave, which lasted until the end of February, early March in most places. And then, historians that's as far as they got, a lot of them, right? Including me when I did work on Winnipeg. I looked at the public health reports for the years after, and there didn't seem to be a lot of influenza in Winnipeg in 1920. But in places like Quebec, there was a lot. So the research is, I guess, spotty is what I'm saying about the impact of the later waves of influenza. There's also some evidence that in some Indigenous communities, there were ongoing, quite serious waves of influenza into the early 1920s. The first wave, the early, what historians called the first wave, which took place in spring of 1918, was largely unnoticed, right? So a lot of cases happened within the military. The military did its best, of course, not to let what was going on with the health status of its soldiers become common knowledge. It was in the final stages of the war. And there was very little sort of public attention to it. And it isn't until later, retrospectively, that those waves are better understood. So, public health took measures that were only partially supported by business or by members of the public in the fall of 1918, and then for the most part dropped them and didn't really return to them. And public health officials had faced a lot of criticism for in places like Winnipeg, the 6-week lockdown that they initiated. So again, I think the lesson of how we handled that is a negative lesson, right? And I talk sometimes in my work about historians also needing slightly different interpretive frameworks for understanding, the movement of infectious disease, and to think of it less as what the great epidemic historian Charles Rosenberg always called the dramaturgy, the way in which infectious disease outbreaks behaved and social responses to them were like a 3-act play. Just as an epidemiologist might, draw that nice chart, historians have kind of also had a similar narrative where closure has always been a big part of epidemic history. So there's like an endpoint, right? In my own work, I was mostly interested in survivors, right? Like how people survived. And so I did a lot of research into families after the pandemic. But that was more a social history. So, we also need to learn to think about disease outbreaks as having a much longer trajectory than we often have, and to deal with them less as episodes and more as, like Rosenberg said, an epidemic is an event, not a trend. And that's not, I don't think that's how we can think of COVID. There probably are infectious disease outbreaks that do fit that more comfortably, right, in history, that you can sort of see they have their period and they come and they go. They may return, but later. But I think our experience with COVID is much more this kind of, sort of flat with small peaks kind of long-term experience, and that we all need to stop thinking in terms of, the 3-act play with the ending.
Yeah, that's a great point. It seems our leaders want to sort of, have concluded, the end of the end credits are rolling, but maybe we're in something more like Gunsmoke or The Simpsons, 30 seasons or so, or a miniseries. So
yeah,
that's interesting. That's a very, very interesting point. Andrea and I wanted to thank you so much for joining us for this interview. We're gonna, get it ready and send you the link as soon as it's up. And
okay,
thank you so much for spending your time with us and sharing your very interesting perspectives.
Yeah, thanks for asking me, and good luck with everything.
Thank you.
Okay.
Thank you.
Stay safe.
Bye-bye.
Take care.
Bye-bye.